Okay, I think we can go ahead and get started. It's my pleasure to welcome to our department and introduce this afternoon's Grand Round speaker, Dr. Paige Burkholder. And after graduating from our very own University of Arizona College of Medicine, she has spent her professional career in New York City in a variety of clinical and academic settings. She's a former faculty member of the Columbia College of Physicians and Surgeons and presently serves as a clinical assistant professor of psychiatry at the State University of New York, Brooklyn. In this capacity, she has instructed a number of residents and medical students, and for about a decade has served as the director of outpatient psychiatry for the downstate campus. Dr. Burkholder is also the medical director of the partial hospital program at the Kings County Hospital Center in Brooklyn. Prior to this position, she served as that facility's medical director of inpatient behavioral health, and before that as the director of the King County Hospital Department of Chemical Dependence. She has been involved in several research studies evaluating psychopharmacologic interventions in psychotic disorders. She is also a co-founder of the Institute for Cognitive Therapy of Psychosis. She additionally has spoken about the topic of cognitive therapy for psychosis in a number of national venues and has served as a consultant in this capacity as well. This afternoon, Dr. Burkholder's talk is entitled Cognitive Therapy for Psychosis, an overview and case examples. Dr. Burkholder.
Thank you very much. It's great to be back at the U of A. It's been a long time. And I made it out before the snowstorm, and my son is extremely happy to have a snow day. They never give snow days. I do work at Kings County Hospital most of my clinical time, so that's a very different setting from anything here. It's been a place that's been through a lot of chaos recently. We've hired 350 new staff members in the last year because of a lot of problems at it's a big city hospital. But in the midst of all that, I became very interested in the treatment of schizophrenia and psychosis, and I was lucky enough to be working with Dr. Peter Wyden when we started to do a pilot study looking at cognitive therapy with medication adherence as an outcome. And because of that, I got to go to the UK and get trained for about 3 or 4 weeks with Douglas Turkington and David Kingdon, who are some of the founders of cognitive therapy for psychosis. So that's sort of where my background came from. It's a topic that I really, really enjoy talking about, so I hope that you have a lot of questions. I'm going to give you an overview of this specific intervention. It is based on cognitive therapy. It's based on Beck's model, but it is an adaptation of that. I had some lovely slides I couldn't quite get to go on to the change, so I'll have to fill you in about that. Just so we remember that thinking about thinking isn't a new topic. This is a quote from Shakespeare, from Hamlet. For there is nothing either good or bad, but thinking makes it so. The idea behind cognitive therapy is that the way that what you believe about the world influences the way that you feel about the world. And if we can change our beliefs, then we can change our response to what happens in our lives. And just to give you an idea of that, it's based on what people call an ABC model, and I think many people are very familiar with the basics of cognitive therapy, especially treating depression and anxiety. But if you look at the ABC model, the A is the activating event, and the B is the belief about it, and the C is the consequence. So one of those things I was going to give you as an example was that when we heard in Brooklyn that there was going to be a blizzard, dumping snow, 1.5 feet of snow in New York City, the Department of Psychiatry was running around, who's going to be able to get here? We won't have enough nurses. Will the patients even come? And so our belief about this blizzard was that it was going to really be a very difficult situation. It was going to be a horrible thing. Now, my son, who's 10, had a very different belief about the idea that there was going to be a blizzard. That is that he had a snow day. Because they never have snow days in New York. So he didn't have to go to school. So the same activating event, which is a blizzard, depending on your belief about it, has very different emotional outcomes and consequences. So we're going to look at cognitive therapy, which has been an accepted evidence-based treatment for depression and anxiety. But what about psychosis? And my friend Peter Wyden used to say, you mean if all else fails, talk to the patient? So this is an idea of looking at cognitive behavioral therapy and schizophrenia. Most of the work came from the UK. In fact, interestingly, Tim Beck didn't even know that much of this was being developed until it had already been tested and tried in several randomized controlled trials. It's now considered standard in the UK. It's not as standard in the US, although it's becoming more of recommendations. And these treatment techniques are modified. So, in fact, in many ways, I think that it helps to be comfortable with people with schizophrenia or psychosis more than it matters if you're an expert in cognitive therapy. Because as you'll see when we go through this, you really have to be able to talk to and listen to people with psychosis. So another big question. Many times people were told psychotherapy made schizophrenia worse. In fact, that's what I was taught in my residency, that there was good data, came from the psychoanalytic studies, that talking to people, in fact, made their psychosis worse. And there were fashions in the treatment of schizophrenia, from dementia praecox to the psychoanalytic idea of schizophrenogenic mothers, to more recently our genetic ideas, the decade of the brain, the biological models. And now there's sort of an idea that maybe we can, by talking to people, by helping them manage their symptoms, help them manage the functional problems that come with schizophrenia. There's a Cochrane overview that said that, this is from, I think, in the 80s, that said that dynamic and analytic therapies have not been subject to enough evaluation, and that there's evidence that, in fact, they can make schizophrenia worse. So why would we want to do this? I mean, you know, why would we want to subject people to something which there might be data that might make it more difficult for them to recover? But what I'm going to present to you is that this is a tool to put in your toolbox to add to, and this is not to take away from the biological treatment of psychosis, but to add to the way that you use those tools. And the question is, well, if all the other methods are so good, then why do people stop their medications? And they get sick again, and they relapse over and over. Why do they have denial and poor insight? So even though we have great antipsychotic medications, although we know they have a lot of side effects that people are concerned about, we also know that people with psychosis have poor adherence, poor insight, poorly developed coping skills, high likelihood of relapse, treatment resistance, and so forth. High levels of victimization and suicide. The Katie trial, we were actually a Katie site at Downstate, and there are many things to be learned from the Katie trial, but one of the things that struck me was that 74% of patients in that trial discontinued their study medications before 18 months, and the median time to discontinuation, for whatever reason, was 4.6 months. That means that a lot of people don't take the medicine, no matter what you do about it. And this is looking at a time frame of relapse of schizophrenia in patients recently discharged from the hospital. So you can see that, I think my mouse works here, you can see that they start with symptoms. Symptoms get better as they're in the hospital. They do a little bit better over time, and then they relapse again. And we think that that's, a year to 18 months, and people get sick again. Mostly, I think, because they stop their medication. And insight, which we all wish people would have, meaning, yes, I know that I have a serious mental illness, yes, I know I have to take medication the rest of my life. People don't often have insight, and it's the most common, lack of insight is the most common symptom in schizophrenia. That's from going back to 73 from the WHO study. Again, not to say that this kind of intervention is to be done in a vacuum. It's all part of a biopsychosocial model. You definitely have to have the medication interventions. This is not to say at all you don't need really good psychosocial interventions, clubhouses, partial hospitalization programs, social skills training, etc. But what I'm going to say is that maybe this is a way to help people understand adherence, to get them to connect to the treatment, and to get them to feel they have some more power over their lives. So psychoanalysis worsens schizophrenia. We think delusions and hallucinations are fixed. Supportive psychotherapy can be helpful in reducing the shame and the stigma. Most of us do psychoeducation, and I think that's certainly what I was trained in. I was trained that that's what you do. You teach families, you teach consumers, they have a biological brain disorder, that they need to take medication, that there's a chemical imbalance, etc. Has anyone here ever drawn a synapse for their patients? You know, here's a synapse, here's where the dopamine comes out, and here's where the dopamine connects, so there's too much dopamine. And so that's, a lot of what you do in psychoeducation. This is dopamine. The medication helps the chemicals. You may have to take it the rest of your life. You have a biological brain disorder. But they say that the brain disease model is contentious for many patients. They may not like being told you have a brain disease, right? So here's Darth Vader. You are a schizophrenic. And they say it demoralizes them. Your brain is defective. Now, I mean, this is just to say that it's maybe a tough thing to hear when you're being told, especially, say, a first episode young person and their families, you have this very serious biological brain disorder. Now, it's not to say that you don't believe that they have imbalances in the brain or that medications work, but it may not be the best place to start a dialogue. So, CBT can help insight. It may actually get people to stay in treatment. There's evidence that it's efficacious, and patients, carers, and providers really like to do it, so that's a good reason. CBT started classically with Tim Beck, the cognitive triad, which was a negative view of self, experiences in the future, that we make cognitive errors, that we have dysfunctional thinking. Interestingly, Beck wrote a case study in 1952 using a cognitive kind of model for the treatment of schizophrenia. But he didn't go any further with that. He went on to treat depression and anxiety. Interestingly now, and he's in his late 80s, he said that he decided to save the easy stuff for last, and he's working on schizophrenia and suicide. So what are the evidences of efficacy? At this point, there have been a number of randomized controlled trials. They show, in general, that this treatment works for people, especially positive symptoms, that it helps prevent relapse, and that it has lasting effect over time. It's now recommended in the PORT guidelines. It's recommended in what are called the NICE guidelines, which is the UK's version of national recommended guidelines, the APA, American Psychiatric Association, etc. All right, so we're going to get to how you really do it right now. Where is the evidence that it really works? The most randomized controlled trials are for people in 18 to 65, if you see, follow the purples, Caucasian. They have persistent chronic symptoms, and not so much, there isn't as much evidence for younger folks and early episode, although there's new trials coming, especially out of the UK and out of Mass General, that look at prevention of first episode or preventing relapse in first episode. Okay, so what do we really do? Here's coming a very complicated slide. Don't worry about all of it, but it just gives you an idea of the overview, which goes from engaging to developing what we call a normalizing rationale, to a formulation of how you're going to go about working on this, the techniques for delusions, hallucinations, and thought disorder, negative symptoms, and then you do schema level work, maybe, relapse prevention and booster sessions. So let's look at engaging and rapport building. This is nothing new. This is what we think most therapy is based on. You want to have the patient believe that you are listening to them, that you understand what's going on with them. You use a conversational style. It's not confrontational. You can agree to differ, and you socialize and use the cognitive model. And you do a lot of teaching. What you can say to someone is, they don't have to believe that they have a psychiatric illness to do this. They have to have some kind of distress. If the person has no distress about what's going on with them, there's very few places to start in terms of therapy. But the distress may just be, I don't know why my mother keeps calling the cops. There is nothing wrong with me. I do not have a psychiatric illness, but my mother keeps calling the cops over and over, and I keep getting hospitalized. That may be where the distress point is, and that may be where you start your treatment. But it's sort of getting to the point where someone says, but the CIA is following me. You don't understand. They're parked outside all the time, and you say, take this pill. And they would look at you like, well, tell me how the pill connects to the CIA following me. So this is a therapy where we're going to try to help make those kinds of connections for people to get where they may find something that they can actually do to work. Rapport is important. It almost goes without saying. In fact, the studies are that the relationship with the therapist is always the best predictor of outcome, no matter what kind of therapy you do. But when a person has psychosis and has been often not listened to, not paid attention to, people, there's stigma attached to it, their families don't understand why they keep doing this, just to listen to them and to tell you what they have and believe is going on it's absolutely correlated with recovery. Okay. So engaging the patient. And why is it difficult to engage with a psychotic patient? Well, it's interesting. As you start to look at the reasons in the way that you work and do therapy, most of us can understand sadness, which means many of us feel we can understand depression. Most of us understand anxiety, stress. But for many people, we're over here and psychosis is over there. And that is something which this therapy helps you learn how to pay a little more attention to. And I'm going to give you some examples of that as we go through. So the experiences of the psychotic brain seem to be outside the realm of what we can understand. We can't always read their affect. The thought disorder may be there. So what are we going to do? Well, you can ask yourself, if this were really happening to the patient, would I feel the same way about it? So I have a thought challenge for you. Can anybody here think of what would make them run out into the street from their home naked? Fire. Fire, definitely. Fire. Anything else? Earthquake. Yeah. Gun to your head, gun to your child's head. I mean, you can think of extreme measures. Has anyone ever had a patient who was found wandering naked in the streets? I certainly have had several. But if you think of the extreme fear and anxiety that must be going on in the person's head, you can imagine what it would take for them to act in some of the ways that they do. So I think the first place you start is to say, rather than saying you're acting this way because you're sick, to back up and say, what is going on that you are behaving in this manner? Okay, and you want to get more information. Don't jump to conclusions. Really listen, take it at face value, do one problem at a time. Okay? This is my favorite slide. It says that you collaborate, but you don't collude. And the way that you can think about that is, a patient says, my mother and my sister are always talking about me, but only when I turn my back. And I have evidence of this because when I turn around, they're quiet. And you believe me, right? You believe me. Now, if I said, oh, right, yes, of course, or of course I believe you, the CIA is after you, people can read dishonesty immediately. So the idea is not to say, of course you're right, to avoid the problem. The idea is to say, you know, I don't know enough about that. I have a patient who is, had a postpartum psychosis, which went on to become more chronic schizophrenia. She was a very intelligent young woman. She had a master's degree. She was a speech therapist, and she was had her first psychotic break after the birth of her second child, and had a repeat after the birth of her third child. And her belief was that there were demons, and the demons were trying to harm her and take her children away. And one of the ways they were doing that was by inhabiting her children, which was a very frightening thing to her because she didn't want to hurt her children, but she also did believe that they could be demons. She was a Seventh-day Adventist, and so I said to her, well, you know, I really don't know a lot about demons, I have to, you know, tell you, but is there anything in your church? Do they talk about demons? And she gave me a website for her church, and the internet is your friend in this kind of work, by the way. I went online and I read about what her pastor said about demons. And in fact, he talked about demons all the time. So the idea that there might be demons in the world was not at all beyond her range of belief. The idea that her children were demons, on the other hand, was a very frightening kind of thing. So what eventually we try to do with this is to have the person be able to come up with some alternative explanations that make sense to them. And I'll give you one example with her that was actually great. She turned out to be a wonderful patient. She was very, very bright, and what she would do would be do very well for a while. Then if there was extra stress, or she would drop her meds, which she would do time after time, she would have symptoms come back, she would call, she would come in, we'd adjust her medication, and she'd be all right. Her husband was very involved with this as well. And there was an episode where she and her husband came into the clinic, and as they walked through the corridor, there was a woman, and we work in Brooklyn with a lot of people from the Caribbean. I think we have the largest Caribbean population outside of the Caribbean in the world, from all the different islands. And there was a woman in the hallway spinning, you know, with a lot of clothes on, and she was spinning and talking to herself. And my patient came in and said, "That woman is a demon, and she's going to try to harm us." And her husband looked at her and said, "Can you think of any other reason why someone in the outpatient psychiatry department at Kings County Hospital might be acting strangely?" And she looked at him and she laughed and she said, okay, I get it. You know, maybe she's got her own issues. But that kind of way of helping her learn a different way of balancing what was happening to her was really very helpful. There's an author, Paul Chadwick, who does a lot of this work from the UK. He's also very into mindfulness and adapting mindfulness treatment to this, but he calls it radical collaboration. And I like that term as well. It's not just, yeah, we're going to work on this together. It's really, we're going to get down and we're going to figure this out together. We're going to try to find out what's happening. So you're going to understand their experiences. You're going to let them lead. You're going to normalize but not minimize what's happening to them, and explore alternative explanations. And by the way, don't neglect side effects of medication, because people can develop psychotic beliefs about medication. My vision is blurry because this medicine is poisoning me, rather than saying this is an anticholinergic side effect and it might be because of this and we'll adjust the medication. This medicine's making me into a zombie, and you know, they have EPS and they're walking very stiffly. So you want to make sure that you explore all of that with them. You also start to teach people a little bit about the ways that our brain jumps to conclusions. There's a lot of evidence now that people with schizophrenia and their first-degree relatives have a very different way of coming to conclusions about things. Are you all familiar with this kind of I would say a gumball choosing, but a bead choosing experiment? This is from Philippa Garrity in London. What she would do is you would show people, you don't really have to have real jars anymore, you have virtual jars. A jar that's 15% blue balls, and the other jars 15% pink balls, and you're going to say to the person, I'm going to take one ball out of one of these two jars, and I want you to pick, after how many times will you be able to tell me which jar it came from? Does that make sense? Does that experiment make sense? So let's say the first ball that comes out is a blue one. How many people would be able at that point to decide which jar the ball came from? Yeah, nobody, right? They'd say it's too early, I can't make that decision. Let's say the second ball is a blue one. Now what? Are you a little more inclined to think it's coming from the mostly blue jar? Or are you still not sure? Third ball is pink. Oh no, now I really don't know what to do. The interesting part is that people with schizophrenia make this decision much more quickly. They jump to conclusions much more quickly than people without psychosis. And this is just a way of looking at the mean number of beads that people need to make this decision. If it's an 85 to 15 ratio in the jars, people with delusions, it only takes them a little over 2 balls to make a decision about which jar it came from. So they really jump quickly to conclusion. People with depression and controls are about the same. It takes them about 4. Okay, and if you mix it up a little more, 40, 60, they all take a little bit longer knowing that. But what you can see is that the way of thinking, the way of making decisions, is to jump to conclusions more quickly. And you can see how that might lead to beliefs or conclusions about what's happening in the world. All right. Now, one of the most important things that we do as we talk to someone is develop what's called a normalizing rationale. And normalizing just means we're going to look at the way our brains think. We're going to decatastrophize the idea of schizophrenia. And we're going to give some alternative explanations to possible reasons why you might have strange experiences. It's based in part on a stress vulnerability model. The reason for that is pretty much everyone understands stress. If you say to people, stress makes symptoms worse, it makes pain worse, it makes headaches worse, and it definitely, we believe, can make psychosis worse, then we can look at stressors and see if that had anything to do with the onset of your illness. We can normalize psychotic symptoms, and part of the way that we do that is by looking at the ways that, quote, normal people can have unusual experiences. For myself, one of these things that was helpful to me was learning about déjà vu. Does everybody know what déjà vu is? Has everyone had a déjà vu? How about, is there anyone here who has not had a déjà vu? Okay. I remember my first déjà vu very well. I was about 5 or 6 years old. I was in my parents' backyard in Winter Haven, where I grew up. And my cousin had a pink blanket over her head and was walking toward me. And in my mind, I thought, I've seen this before. I've seen this before. Maybe it was in my dreams. This is kind of weird. It's kind of cool. And I went to my mother and I said, what is that? And she said, oh, that's just a déjà vu. And I went, oh, okay, it's just a déjà vu, and I didn't get worried about it. On the other hand, if someone had said, that's amazing, you have visions, perhaps, and if you think of culturally about the ability to have visions and the ability to think differently about the world, you might become a shaman, if you're lucky enough to have enough visions. But the idea is that our brain can play tricks on us, our mind can play tricks on us, and especially if we pay attention differently, our mind can play tricks on us. Sleep deprivation, doctors are great at this one. Sleep deprivation does a lot of things to your mind. PTSD, we know that people have flashbacks, all kinds of things that happen. Sensory deprivation, hostage situation, solitary confinement. There are many things which change the way that we view the world and the experiences that we have. Certainly there are psychogenic drugs or hallucinogenic drugs and so forth, but there are also things just in the day-to-day world that change the way that we think. For example, if you've ever had the experience of breaking up with somebody in a relationship or losing someone, the death of a close person, have you ever had the experience of thinking you saw them in a crowd? Or thinking that you might see someone that looks like them, thinking you heard your name called in a crowd, okay? Some of that is just selective attention. We tend to selectively hear our own names. We tend to, when we've lost someone or thinking about someone, selectively see them, even though it's not really them. How about the idea, this is my colleague Mike Garrett likes this one. If you're in the shower and you think you hear the phone ring, okay, and you get out of the shower, and you can't tell, did the phone ring, did it not? Okay, get back in the shower, think you hear the phone ring, okay? After how many times of doing that do you think, I'm just like, there's something wrong, maybe there's a weird sound somewhere, but again, our brain has the ability to play tricks on us. This is something that it's very helpful for patients to hear about, that they're not the only people who have this change in the way they think. This is one of my favorite slides. This is a Gallup poll from the United States from 1989 about what percentage of people they talk to believe in these different things. Black magic, 10%. The devil, 21%. Horoscopes, superstitious, reincarnation, ghosts, God. What do you think is the number one thing that people believe in? Angels. 85% of people in the Gallup poll believe in angels. So if you start to think to yourself, now this is interesting, how do I differentiate faith, religious belief, and beliefs from psychotic experience? The continuum of this starts to happen. Maybe it's just something that I enjoy, but you start to think about things like 13th floors. Just look at the way that our mind looks at the world, and it begins to change a little bit as you start to look at things differently. So many people in the world have this. I have a Pakistani patient who she wears traditional garb, and her mother and she both come. Back in 9/11, they were very scared to come out because anybody that looked Muslim was, very scared in New York City. But they were talking to me about a holiday that they celebrate where someone in the family has to kill a live lamb and sacrifice a lamb, and that's part of what. And then the mother looked at me and said, it's very close to your Easter time. What does Easter celebrate? And I found myself saying, well, Christians believe that Jesus was put on a cross, and then he died, and then he was put behind a rock, and then he rose. And I could see them going, looking at me like I was completely out of my mind. And you start to realize how the stories that we accept on faith can sound very strange to someone who's not of that belief. This is the stress vulnerability model. I love this slide because, excuse me, my friend Alison Brabin, who's from Durham, calls this a bucket. I had to listen 3 times before I heard her say it right. Not a bucket, a bucket. The idea behind stress vulnerability is that everybody's born with a certain amount of vulnerability to stress. Some of us have a very large bucket, and we can take a lot of stress before it overflows. Other people basically have a very small little bucket, and it doesn't take very much stress to overflow. And that explains why some people are more at risk for some kinds of illnesses than others. And there are people for whom not very much stress overwhelms this ability to cope. And it becomes a vicious circle. You have vulnerability and stress. Let's say the symptom that you have is voices. Well, if I have voices, and my belief is that these voices are from God or the devil, and that really is upsetting to me, and I become more stressed, and I have worsening symptoms and reinforces the beliefs, etc., it can really, really escalate. So what we do actually when we try to de-escalate this is we try to basically do what's something called inference chaining, which is try to help people understand the way that they make decisions. Now, the ABC model, we started with that from the beginning, in cognitive therapy, is the activating event is the belief, the activating event, the belief, and the consequence. Let's suppose the activating event is a hallucination. It's a voice. If your belief about that voice is that this is, benign, this is God, God's very nice to me, God's telling me to turn left at the intersection and have, oatmeal for breakfast, the consequence is probably not going to be too bad. But if my belief about that voice is that it's evil and it's going to make me somehow do something I don't want to do, then I'm going to have a very different reaction to that. And this study by Chadwick and Birchwood found that the belief about the symptom was far more important than the symptom itself. And I think we've all heard at some place that people can have voices and not be patients. That, especially in the UK, but I think there are beginning to be more movements here, there are voice hearer movements. And there are many people who hear voices and are not patients. Supposedly Sir Anthony Hopkins, the actor, is a voice hearer. And when he's working, he will take time during the day to listen to his voices. I had a patient say to me at one point he was a Lubavitcher, which is a very strong Orthodox Jewish sect in New York City. And he said to me, why am I different from Ibrahim? Why are these voices that I hear, why is this different than God? And I said, and boy, that's a hard one. And I said, well, all I can think of is that Ibrahim got people to do what he wanted them to do. He took whatever he was hearing, the voice of God, and he was able to make it functional. This young man couldn't leave his house because of all the things that were going on with his symptoms. So again, if we look at the ABC model, hearing a voice, forming a belief, having a response. So let's say you hear the voice and you're trying to figure out, what is this voice, what does it mean? Let's say the belief is, I think I have a biological brain disorder and I better go to the hospital and get some medication. Then that may not be just too distressing. If your belief is this is the voice of God and he's telling me that I'm horrible and I'm going to die, then I'm going to have a very different emotional response. Does that all make sense? Okay. Hallucinations, we have a similar way of working with it. You start to look at, you get very specific with hallucinations. Do you remember what was happening when this started? Do you know whose voice it is? Is it a male voice, a female voice? Can you understand it? Some people just hear noise. Some people know who's talking. Some people say, I don't know who it is. But you try to look at what the rational response to this might be and how you could come up with maybe some counter ideas. So you say, is it like me talking to you now? Can anyone else hear it? Why do you think they can't hear it? You can come up with all kinds of experiments for this one. For example, if the voice says hit him and your belief is God's testing me, you're not going to do it, right? Because God's testing me, I didn't hit them. good, I'm a good person. If the voice says, be careful, and you think that's the devil, and he's watching, you might be very afraid, and you wouldn't go into shops. So the hallucinations are the triggers, let's say anxiety, social situations, cannabis. You hear a voice, I'll never get a girlfriend. You're mentally ill. You stop talking, you withdraw, you drink, you go to bed. You believe that the voices come from a higher power. You start getting anxious, you withdraw more, and it becomes a really vicious cycle. So we did that. So you come up with coping strategies, diversion, socialization, things that we actually did with psychoed. But you also try to look at the voices themselves. You can reframe things in cultural beliefs. Do you think people can read your mind? How do they do that? So the other thing you do is some different kinds of questioning. Peripheral questioning, Socratic questioning. You really try to get people to come up with their own explanations of what's going on. You can do some what's called inference chaining, which is, let's say that they say, well, I think that this voice, the patient I had are demons, and the demons are trying to hurt me. And you can say, okay, so if voices are demons, how would you know that? Well, because they would be saying a certain kinds of things, or they'd be looking at me strangely. Another patient I had who believed in demons, maybe it's something about Brooklyn, told me that people looked at her on the street and on the bus, and she could tell by the way that they looked at her and stared at her that they were demons. So I said we were going to do a little behavior experiment. The first thing she was to do when she rode the bus was not to do anything, just watch people. Just, quietly not stare at them, but try to see it, where do people look when they're on the bus? I actually do this with residents when I'm trying to get them to learn about abnormal movements, about tardive dyskinesia, because you have to know what normal weird movements are before you can know what tardive dyskinesia looks like. And if in New York it's a subway or a bus, if you sit in a place where people don't think anyone's watching them, and you watch what people do with their mouths and their hands, it's often very weird, and they stick things out and they look around. So you've got to know what that looks like before you can say what someone looks like when they start to develop an abnormal movement. Well, I asked her to do kind of the same thing, just to watch what happened on the bus. So she was with her grandson, they were on the bus, and she noticed a woman staring at her. She started to get very, very uncomfortable that this woman was staring at her. And the thought in her head was, she's staring at me because she's a demon, she's going to hurt me. The woman stood up, the other woman, and walked towards the exit, leaned over to the patient and said, "Who does your hair? I love your braids." They're all braided. Now, I couldn't have devised a better experiment for her, because this wasn't at all staring because she was a demon. She was staring at her because she liked her hair. It was a wonderful kind of alternative explanation for behavior that she had interpreted as being demons. My favorite expression for this is called Columbo reasoning. Does anybody remember the detective Columbo? Most of you guys are too young. Columbo was this kind of rumpled detective. He did sort of Socratic kind of questioning. He would never say, "So, did you, were you at 100 Flatbush Avenue and did you pull a gun?" And he would say, "So, I noticed that you have snow boots on and it's not cold out. Perhaps that could be because your other shoes." He would come totally around the question. He would circle around the idea of what was happening and try to figure out if you could find out more that way. So one of the things you're going to do is lead the person to try to explain things themselves. I'll give you a bit of an example from my colleague Mike Garrett. He had a patient who believed that her mother was attacked by a group of thugs who were going to kidnap her and try to murder her, and it was all because of something she, the patient, had done. And she had this vivid memory of these thugs taking her mother outside their house, stringing a rope over the branch of a tree, and trying to hang her. And it was only because she intervened that this didn't happen. So the question was, okay, well, it sounds very distressing. Is the tree still there? Is it still outside your house? Oh, yeah, it's still there. And how big is the tree? And again, you've got to do this with real curiosity. If there's you really have to open your mind. If there's a bit of, "Oh, okay, how big was that tree?" You're going to be in trouble. But how big was the tree? Well, it was a kind of a normal tree, And how big was the branch? Oh, maybe about 3 inches around. Okay. How big's your mom? Well, she's normal sized. How much do you think she weighs? Well, about 140, 150 pounds. How big was the rope? Oh, it was a big rope, really big rope. So they went through this, and the woman said, but it happened. I am absolutely sure that it happened. Next appointment, a week later, she said, you know, I think I might have misremembered that. And the idea is that we all misremember things. We all make mistakes in our logic sometime. What you can do is to help patients is try to get to the place where you offer some alternative explanations. You don't say, it's not possible to have hung your mother from that rope. But you do lead to that point. You investigate to the point where the person themselves comes up with that idea. You do a lot of homework. By the way, you have to do your homework. You know, if you say, well, I'm going to go to the internet and I'm going to look up something, you better do it. And you test things out. We've had one of the residents that we work with did a wonderful experiment where one of his patients thought that people walking by him in the street were looking at him and saying bad things about him, but only once they passed him. So they started out by standing on the porch of the building where we were working and just watching people walk and watching who they looked at. And then the experiment was that the resident and the patient would walk together down the street and keep an eye, and the patient was to keep an eye on who looked at who. Did they look at the resident? Did they look at him? And after doing that once or twice, he started to say that he realized that he didn't think people were really doing that the evidence just wasn't there. Had a patient who thought that people in white cars were following her. The interesting thing is when she was sick, she would pay attention to the white cars. And if you do that, you know, you pay attention to a lot of white cars. Negative symptoms are harder to treat, I think, in many ways. They're so hard to pull apart from depressive symptoms. I think the one thing to remember is sometimes what appears to be negative symptoms, withdrawal symptoms, may be positive symptoms that people are afraid to tell you about. This is actually a medication good news, but there was a man who we were treating in our MICA day program for years. He never spoke to anyone. He always looked so depressed. He would barely make eye contact. He simply always looked depressed, withdrawn. Interestingly, and this was for years that he would come and go from this program, I was covering for another doctor last week, and I saw him for medication. And someone had finally actually bumped his Risperdal a little higher than usual. They went up to 8 milligrams. He looked at me straight in the eye and he said, "The voices are gone." Now this is a guy who I would have judged had a lot of negative symptoms. No eye contact, poor energy, didn't interact with anybody. Turned out that actually he was constantly hearing voices, and he couldn't pay attention to anything, so he kept his eyes down and he didn't look at people. Now that's a medication change, but just the idea that we start to try to think of other explanations about how people might be acting. Social phobia, agoraphobia, those are things you need to look at too. So first you treat the positive symptoms, treat the neuroleptic side effects, treat the depression. Okay. Oh, mastery and pleasure. Does anybody know about mastery and pleasure recordings? That's another cognitive therapy technique you use more in depression. But the idea is you have people rate any activity that they do, either based on mastery or pleasure. Because there are some things you have to do and gain mastery in that aren't much fun, but at least you gain mastery in them. And if you have someone who basically never gets any pleasure out of anything, I supervise someone at the Manhattan VA whose patient he's doing things. He's going out, he's in a clubhouse, he does things, but he never enjoys it, ever. And I said, well, I think we're going to have to get very concrete with this, because you're going to have to ask him to rate everything that he does instead of, oh, nothing's much fun, to say, well, did you get out of 1 out of 10, a 3 in mastery, a 4 in mastery? See if we can change it, see if we can work on it. Let's see, medication issues. Peter Wyden and I did a pilot study in Brooklyn looking at adherence to medication as an outcome measure for cognitive therapy. And the reason that Peter is very interested in adherence, which is very hard to measure, it turns out the best way to measure adherence, which is not very good at all, is to see whether people fill their prescriptions. And we all know that they can fill them and put the entire full bottle in a drawer and never take it. But it turns out that the best way of looking at whether people take oral medication is whether they actually filled the prescriptions. But what we did was, so the outcome measure was we had, everyone got their meds from our pharmacy, and so we could see whether or not they filled the prescriptions. And we did, it was just a pilot study. I think we had 16 people in the CBT arm. And we did show some good effects from this, but part of that is that we put medication in a context of health beliefs. So rather than saying, here's your antipsychotic medication, we sort of looked at people's belief about all of their health. You know, do they think that there's anything they can do to make themselves well? Is there, you know, what do they think about medicines in general? Is it normal or not normal to stop your medicine if you're a first episode schizophrenic person? It's absolutely normal to stop the medication. Ask most people if they ever finish their entire course of antibiotics, if they get better after the first 3 or 4 days. Very few people do. So instead of feeling like, what's wrong with this person? They don't take their meds and they decompensate all the time. Starting to look at beliefs about health, beliefs about the medication, beliefs about what they need to do to get better really helps you be on a more even keel with your patients. The final goal is to move the locus of control for the patient from the outside, from the inside to the outside. Do I have it backwards? I think I just did this backwards. Yeah, I did it backwards. Never mind this slide. It's from the outside to the inside. The idea that, that someone outside is controlling your voices. God is the reason for the voices. Voodoo is the reason for the voices. Just something that you might be able to manage. The idea that you might be able to have some control over whether this happens or not. We do like to do relapse prevention sessions. Most of the course of this is somewhere from 20 to 25 sessions, and then relapse prevention. Things you need to watch out for. Not collaborating, confronting instead of collaborating, colluding, humoring, going too fast, going too slow, lack of formulation. I do a lot of timelines with people. We focus a lot on the first episode, what was happening around that. If you do a timeline and put arrows for stressors, it's maybe not exactly, because we all know that stressors also happen at about the age of onset of schizophrenia, but it's very helpful for the patient to see all these multiple stressors coming together at the point they first got sick, because then they start to look at this as something that maybe they can manage in a way. So those are some of the things that you want to be careful of. Genealogy is also a really interesting thing that you want to try to do with people, because people have, I was trying to keep straight somebody's family, and it was so confusing. This is a woman that I interviewed on an inpatient unit who claimed to have multiple children, multiple husbands, all kinds of different things, and I couldn't even get the delusional system straight. But if you got her to do a genogram, with her, you know, with her belief in all her 7 children and her different husbands, that's a great way to go about doing that. Well, here's you with the circle, and here's your husband with the square, and here's where the kids are, and here's what, you know, that's a great way to just concretize what happens. There is a lack of precision and definition of schizophrenia. I think as the DSM-5 comes out, we're all going to be looking at this. I don't think schizophrenia is one diagnosis. I think we've lumped things together, and we call them schizophrenia, but they may very well have very different biological substrates or things that go on with them. So you might want to look at somebody as having had a trauma. You might want to look at somebody as having had stress. Someone may have a family history, and that's going to do it. You want to work on, is the medicine stopped? Does that help you get decompensated? Okay, so we use the stress vulnerability, we normalize, we use self-disclosure as a technique. I use my deja vu example a lot with people. You use your own thoughts about what happens. You use yourself as an example. It's not that you're going to reveal everything about what's happening, but you can use the idea that you've made mistakes in the way that you think and reason. You look at alternative points of view. So in conclusion, the cognitive therapy seems to be an efficacious way to add to pharmacological options. And we can look at core symptoms, delusions, and voices. There's new data coming out from multiple sites about preventing the onset of psychosis, or perhaps delaying the onset of psychosis. There's been some trials with medications using, say, low-dose Risperdal and so forth in people with prodromal symptoms. What they're trying now, there's a site at Columbia and there's a site at UMass and also in Glasgow, where they're actually looking at using CBT for at-risk populations. The idea being, in some ways, even if you can delay the onset of psychosis by 2 to 3 years, if you take someone from 18 to 21, in that period of time, they may have developed more close relationships, they may have finished school, gotten a job, really put skills into their toolbox that will help them if they become ill later. So that's one of the ideas. The other is using it in first episode schizophrenia. It's now, I don't know if you know this, but in the UK now, a huge amount of money has been put into the first 3 years after diagnosis. There are these teams that everybody who's picked up within the whole system there gets intensive care for the first 3 years after diagnosis. And CBT is a big part of that. This is a picture of Newcastle on one side and the Brooklyn Bridge. Just the idea that we're going to take some ideas from the UK, we're going to put them into the US. There are more and more sites around the US, and I'd like to thank my collaborators for the Institute of Cognitive Therapy, and we have a group we call the Beckfest, because we go across, sometimes in Europe, sometimes here, meet with Tim Beck, and he's a hard taskmaster. He's really pushing everybody to keep looking at new ways of using this. So thank you, and I think we have about 7-10 minutes for questions. So if anybody, please ask questions. Thank you. Must be questions.
Yeah, there are.
Yes.
Well, just starting with what you last, well, where is the Academy of Cognitive Therapy?
Oh, well, the Academy of Cognitive Therapy is from Philadelphia. It's all cognitive therapy. It's not just psychosis. So it's I think it's at the University of Pennsylvania, I think is where the site is. If you look at Academy of Cognitive Therapy online, you'll get that.
And then I'm curious to know why many of your references were so old. They're like 30 and 35. Isn't there anything new?
Oh, yeah, there's a lot that's new. I'm sorry. I tried to edit this, but I did it on an Apple, and I couldn't bring it here. Yeah, there have been meta-analysis. There's a Cochrane report from, I think, 2007. There's several meta-analysis looking at it. Cognitive therapy is interesting. It is effective, but it's not, more effective than other kinds of things. A lot of people now are looking at it in combination with social skills training. David Penn at UNC and Eric Granholm at University of San Diego are combining cognitive therapy with social skills training, because again, if you need some help with social, making eye contact, sort of the concrete things of social skills training, and then you use the cognitive therapy to actually address the actual symptoms themselves. So yeah, most of the references actually are more recent, and so that may be my fault. Actually what I'll do is I'll get your email or give you mine, and I'll send you a bibliography. Yeah. Yeah.
It seems like the model was applicable mostly for people with active psychotic symptoms. And I'm wondering how it changes for clients who present initially wanting therapy but might be in remission.
Very good question. I think that if someone is not distressed by something, it's not going to do very much, because you really need someone to have something they actively want to change. So I think of a lot of patients who've been on meds for a fairly long period of time, who watch TV all day. They really aren't very active. And I think that's where the behavior part comes in, the activating kind of setting behaviors for them. If they're not actively having symptoms, I think it's hard to figure out why you would do this. The best data is about refractory symptoms, delusions or hallucinations that are more chronic. That doesn't mean that it won't work in other settings, but that's where the most data has been done. People who have chronic voices or chronic delusional systems. I have a colleague at Cornell, Yulia Landa, who's doing all groups. And she's actually got she's getting fMRI data, which is really cool, about changes with the cognitive therapy. But she has groups for delusions, and they do a lot of psychoeducation. They learn about the ABC model, and then they share their own beliefs, and they share about how they can see somebody else, they can say, oh, look, I can see why that idea might be a delusion, but I don't see why mine is a delusion. But what they work on is the idea of changing beliefs, that you can't change the activating event. That's pretty much there. And the consequence comes from the belief. So what we're going to work on changing is whether our beliefs about what happened can be looked at in some other way. So that, and often I find actually with my residents who have sort of medication clinics, you see them every 3 months, they get their meds, they don't want to come more often. Once we've done this kind of training with them, we challenge them to take a medication patient and try this kind of technique. And it's very interesting how if you talk to somebody longer, you actually may find that they actually do have a very fixed delusional system, or they have beliefs that they just haven't talked to anybody about in a long time because no one wants to listen to them anymore. And that belief really does influence how they are in the world, the reason they can't get a job or the reason they don't want to leave home. So that's where I kind of look at it. If they say, I'm fine, doc, shut up, I'm not going to go too far with that. But what I find when I've been learning these techniques is that the most fun in some ways is almost the first time you talk to a patient after you've gotten some of these ideas, because it changes, for me, the way that I listen to what's going on. I was thinking about an inpatient, very violent young man who was constantly getting, new admission, first onset, constantly getting in fights, hitting staff. He hit one of the doctors, he pushed him out of the way. And about a week later, came up to the doctor and said, "Oh, you're my doctor? I don't remember seeing you before." And the doctor said, "Well, I remember seeing you." He said, "Oh yeah, I thought you were trying to kill me." And again, that idea that if you try to think where the person was, he can't. He's hospitalized, he's put in handcuffs, he's brought into an inpatient ward against his will. He thinks everyone's out to kill him. And then gradually, he unfortunately, got more medication and he became a little bit less delusional. And then he said, "Oh, well, the reason I hit you was because I thought you were going to kill me." Of course, we want to avoid those kinds of confrontations. But I think, just talking to someone and hearing the way that they think or they've explained something. We tend to think that people with delusions are illogical. They're often very logical if you go back and figure out how they made the assumptions. And it often tends to be very much based on what's really happening in science, like the idea of a microchip in your brain. Now, I'm sure that people 200 years ago didn't think there were microchips, but the truth is my dog has a microchip, and I have to say I thought it was like a GIS, I thought, oh, maybe if he got lost in the park we could find him. It's not like that, they just can scan him. But the truth is, to think that you have a microchip that has something controlling you is not such a bizarre out there idea anymore. So, we really have to think, of course the assumption, when you see someone walking down the street talking to themselves, 3 years ago, what was your assumption? As my husband would say, that's one of yours. Now what's your assumption? They got a Bluetooth, right? So just in that amount of time, our assumption about what that behavior means, and that's not a cognitive thing, but it's great for patients. Just tell them to put on a Bluetooth. If they're going to talk to themselves, they might as well, not look strange doing it, I guess, yeah. Other questions? Yeah.
I was thinking about what you said about the Lubavitcher kid, and how he said he was like Abraham, because actually if he was adolescent, from an adolescent's point of view, or a kid's point of view, or a young adult's point of view, Abraham was told by God to kill his child.
Yeah.
So how do you work with the family, and how do you take a cognitive approach by pulling in this Lubavitcher family and saying, tell your son that God did not tell Abraham to kill his son? I mean, essentially they're all buying into the same system, that just because a ram showed up, this kid wasn't murdered by his father. So you're sort of dealing with
Yeah, I think you have to be extremely sensitive to cultural beliefs and to not intervening cultural beliefs. The question was, how do you address a family when they have a cultural belief about Abraham trying to, being told to kill his son by God, etc. I think you have to be very sensitive to cultural beliefs, and you have to look at what's dysfunctional about it. So hearing a voice per se, and for a long time with this young man, by the way, he hated it when I called it voices. He said, they are not voices. I am hearing my landlord and his wife talk about me, and the wife was trying to seduce him, and all kinds of things were going on, and he kept moving, kept changing apartments. It was very difficult. And the in with him, actually, was when he started to have it follow him between his apartment and the yeshiva. When the voice started following him, he couldn't figure, and I'd say, now, how does that work? No, I didn't say it that way. I said, how does that, how does that work? How does it follow you? Radio waves, there's all kinds of explanations. But for him, it finally, he kind of said, yeah, I don't know. I don't know how that works. And actually, just a quick story about him, which was very cute. He actually got into Brooklyn College, which is a pretty good college. He transferred from a part-time college. And he went in to take a math test, and he had written some things on a piece of paper, and they took it away from him and said that he wasn't allowed to have it in there. And but he got extended time for his test and stuff. And he came to me and he said, I need a letter. I need a letter saying I was psychotic, and that was why I took this piece of paper in there. And I said, well, were you psychotic? And he said, no. And I said, well, why did you take the paper? Well, I thought I was allowed to have it. I said, did they let you take the test? He said, yeah. I said, you're not in trouble. But I just thought we'd gone from him absolutely refusing to be calling it voices to saying to me, would you give me a teacher's, a doctor's note for the teacher that says I was psychotic? And I'd just say, you weren't. You just made a mistake. But so to sort of normalize his behavior. Any other questions? Yes?
When you're dealing with more challenging patients, high-functioning patients, do you get the same kind of efficacy with CBT?
I think you might get more, actually. It's people who are able to work with you in terms of studying and the question about high-functioning patients, does it work as well with CBT? I think, and this is not bipolar patients, because that's a whole other area of study, and I think in some ways more difficult. But I think when people, for example, don't want to take medication, and say, absolutely, from the top, I'm not going to take medication, but I will talk to you about this symptom that I'm having. That you can use the fact that they're curious enough to work on it to your advantage. And they may actually eventually say, I've heard that maybe there's some medicine that might help. So your goal eventually is to balance medication with the symptoms. But it's always about functionality. It's not about the symptom per se. But if they are distressed by something going on in their life, whether it's the CIA watching them or their parents talking about them behind their back, that is the thing that you're going to work with them on and look at other alternative explanations.
I guess what I anticipate that be able to give you some very logical reasons once you do some of the techniques. I was thinking about the example you used of asking, well, couldn't this, you're on the bus and this person has now been staring at you, but what they really wanted was, and what occurred to me was based on the higher IQ, which is, I guess, more often than not in psychosis, is that they'd say to you, well, yes, she determined that I knew she was a demon and so pretended to be interested in my head.
Yeah, I think we've all had that experience with paranoid patients where you quote, shoot down one explanation and they come up with another one and it channels into the other things. I think what you do there is you place a seed. It's all about getting your foot in the door. It's about trying to find that 1% of them that doesn't believe the other part. Could it possibly be something else? And the fact that you're willing to keep working with them on that other possible explanation is, I think, what keeps them engaged. My finding has been that people are very excited about doing this kind of treatment because in many ways their families have given up on them. You know, their doctors don't want to hear it again. And what you're actually doing is very directly addressing the symptom, which is what they're bothered by to begin with, right? And I realized that I didn't have a bibliography that was attached to this, so I will email that to Kylie and make sure everybody gets that, okay? So there's more up-to-date information. There's a couple of really good books out. Tim Beck has a book, it's about a year old, out on psychosis. And Turkington and Kingdon have a new one with Jesse Wright from Louisiana. No, from Kentucky, sorry, Louisville, that has a DVD with patient interviews on it. Yeah,